Okay, this is part 3 of back pain, Rogers theory, that's me, Dr. Rogers, of ischemic, lack of blood flow, and biochemical causes. And these are all preventable things. So here's a lumbar spine x-ray. This would be the top sacral vertebra, S1, lumbar L5, L4, L3. And these are bulky bridging osteophytes. Osteobone phyte is a spur, like a bone spur, so osteophytes. And what happens is when the disc degenerates, you can tell the disc is degenerated by its loss of height, or desiccated is another word for it. You'll get abnormal motion at the level of the segment, the vertebra above and below the disc. And the spine senses that. It has proprioceptors that sense that abnormal motion, and it starts laying down bone from the VB below to the vertebra above, and then they meet each other and they fuse to fuse that segment so you won't have abnormal motion anymore. Because what the spine is afraid of is the abnormal motion is going to keep progressing to the point where it damages the nerve roots in the spinal cord, and then the patient would die in the wild. Okay, these bulky osteophytes, their medical name for this condition is called DISH, and it means diffuse idiopathic skeletal hyperostosis. It's also called Forestier's disease. Okay. But the point is, this is the only thing the spine can do. It's like the Ralph Waldo Emerson quote, from the 1800s. He said, the hedgehog is only one trick, but it's the best trick. It'll play dead and the other animals leave it alone. The spine is only one trick, but it's the best trick. It just fuses wherever there's abnormal motion. And that's how you can understand everything that happens in the spinal degeneration. Okay, so here's what it looks like over time. When you get failure at one level, like let's say you have this bone spur, you fail with this level right here. Well, let's say you fail, let's just start right in the middle. Let's say you fail at L1, 2, lumbar vertebra 1 and 2. The bone spur will form anteriorly of DISH, diffuse idiopathic skeletal hyperostosis. And now once this segment becomes fused by this bridging bone spur, now you'll have increased stress upon the disc above and the disc below. So those will undergo accelerated adjacent segment degeneration. And then when those fail, then you'll get accelerated adjacent segment degeneration at the disc immediately below that and the one immediately above that. And the whole process will work itself all the way up from the lumbar spine up to your skull and down to your sacrum. So the entire spine will become fused. This is very common. I see this every day. Okay, so here is the thoracic aorta, abdominal aorta, and the orange right here is calcifications associated with calcifications and stenosis of the lumbar artery. In the chest, you'll have like thoracic spinal arteries into thoracic arteries, okay? Intercostal arteries that run along the rib. All right, so anyways, you can also fuse across the disc space, and because there's a vertebral body above and below, this is called interbody fusion, okay? You can also fuse along remember we talked about the posterior longitudinal ligament running on the back of these vertebrae? So you get OPLL, ossification of the posterior longitudinal ligament. Now, back when I was a resident in the 1990s, the journal articles would say stupid things like, OPLL is a rare condition seen most commonly in persons of Asian descent. And what a load of BS that is. I see it all day long in Western patients, every day, no exceptions. It's super common. All this stuff is the same disease. It is simply the spine attempting to fuse itself to prevent abnormal motion. And then that concept of accelerated adjacent segment stress and subsequent degeneration explains how it goes zip, all the way from the top to the bottom of the spine. And then the person's screwed, okay? Because their whole spine's fused. Then they're weak. I'll show you the consequences of that in just a little bit. This is how you want to start reversing your disease as fast as you can, because the longer you putz around continuing to eat a crappy diet, the more you will just destroy your spine, destroy your brain and everything else. The disease, it starts out when you're young, being a little injury, but you're okay. The older you get, it's just destruction, destruction, destruction. So you want to stop it all. You can dramatically prevent this stuff, and you'll just feel a lot better. So here's the lumbar arteries, in red coming off the mid-height of the vertebra, okay? All right, now here's showing what happens when a patient has spine surgery, okay? So let me shrink my image here. So when the person starts out with spine surgery, first of all, they hadn't operated, but they decided to operate on this level for whatever the reason. And these are pedicle screws coming in on lumbar vertebra number 5 and number 4. So it's an L4-5 posterior pedicle screw fusion, okay, instrumented fusion. Within 2 years, you're starting to see a little narrowing of the posterior disc space here at L3-4, maybe a little narrowing of posterior disc space here at L5-S1. Now at 5 years out, notice that this disc space here, which previously was totally normal, and the one below it was, actually they operated on this level because this level is desiccated and degenerated. So these things, you would just have to cut this one and move it up. They operated on L4-5. So this was a normal looking disc, and so was 3-4 disc. Okay, 5 years out, 3-4 is becoming narrowed, 5S1 starting to become narrowed. You're seeing a little bit of sclerosis on the end plate cortical margin. Okay, now you go out 9 years, and you can see that L3-4 is not only having progressive narrowing of the disc space, you also have some retrolisthesis, posterior slippage of L3 relative to L4. Okay, and now let me get myself out of the way here. And now if you follow this out to 13 years, you can see further narrowing of L3-4, some narrowing of L5-S1. Not quite as bad at L5-S1, but this is progressively worsening. Okay, so this is accelerated adjacent segment degeneration. This patient was pretty young when they operated on. You can tell because this is like as normal as it gets the spine. This patient was probably in their 20s. But they're they're progressing towards this extending all the way up and down the spine. There's kind of a little hint of it. You can see the beginning of the bridging osteophytes as the spine tries to self-treat itself for the segmental instability and the posterior slippage of L3, the retrolisthesis of it. So this is the typical progression after surgery. And you would get the same thing after disc degeneration, but accelerated adjacent segment degeneration, that's a key concept for understanding how it spreads all the way up and down the spine. Okay, now I want to also show you some things, supportive evidence, like how did I become convinced that I was right and I knew that this is what was going on? Well, when I see a fracture, so here's a fracture of the vertebra here, and one of the things you're going to notice is that you start seeing these bridging osteophytes as they try to stabilize the segment with abnormal motion. So this is a wedge deformity. Instead of being shaped like a rectangle or a square, this vertebra is now shaped like a wedge, like a door wedge. And the anterior part of the upper end plate is quite flattened, okay? So the spine is growing bone spurs to fuse that. So what I'm trying to say is this is not a diffuse degenerative process related to aging. This is a focal process trying to fix this fracture here. And that's what those burn spurs are for. There's a subtle fracture of this upper end plate right here, but there's no bridging osteophyte. So this one's more acute. This is an older fracture because it takes time to form these bone spurs. Okay. So that's one way you can tell the chronicity of a fracture is whether or not there's bridging osteophytes. If you look at an MRI is even better. I mean, MRI, you can see if there's edema. There'll be fluid due to attempted healing. All right, this is just a couple of arteries showing patients with diffuse with DISH have increased atherosclerotic calcifications. DISH of the spine, pathophysiology and management, increased risk in patients with diabetes. Okay. DISH is associated with increased risk of stroke. Yeah, the reason all these diseases are associated with stroke and hypertension and diabetes is because they're all the same thing. They're manifestations of ischemia. Like I was saying earlier, almost all the patients have hypertension and diabetes causing ischemia of the spine, and that's going to lead to degenerative disc disease and subsequent DISH, diffuse idiopathic skeletal hyperostosis. Okay. All right, now here is DISH associated with lower lung volumes in smokers. So what's going to happen is you not only fuse the disc vertebrae, you also get partial fusion of the costovertebral junctions, meaning where the ribs intersect with the spine, and that's going to lower their motion. Plus the spine having itself fused, you can't fill your lungs with as much air, so that contributes to lower lung volumes in current and former smokers due to DISH. So smoking cigarettes also causes atherosclerosis, predisposes to ischemia, okay? Lack of blood flow to the spine. Now here's an interesting study. This was a study done in Europe. Diffuse idiopathic skeletal hyperostosis in ancient clergymen, for example. This is one of these like paleontology studies. So they dug up a bunch of graveyards. They're digging up graveyards around where these clergy, where they think there were clergy and sort of the aristocrats, high-ranking citizens. And they noticed when they looked at their spines, the graveyards where the rich people were buried, there was a lot more bridging osteophytes of the spine. That's because they had high-fat diets. They had a lot of alcohol. They had a lot more diffuse idiopathic skeletal hyperostosis with those degenerative disc disease leading to dish. Bridging osteophytes diffuse those degenerated segments. So that's what they got here. I'll show you one of the spines. So here's one of the spines, and you can see that the vertebrae are fused together by these bridging osteophytes. Okay, and then the poor peasants, when they dig up the peasant graves, they were eating turnips, so they don't get much or any hypertension or diabetes, so they won't have fused spines like this. They'll have much less dish. All right, here's showing you the appearance of some of this stuff on an X-ray. So here is the aorta with atherosclerotic calcifications. The lumbar arteries are going to come mid-height, and you can see this is gaseous disc degeneration of a degenerated disc. So gaseous DDD is degenerative disc disease. Here you see that the disc is so degenerated you started to form bone across the disc space. So this is IBF, interbody fusion, fusion between vertebral bodies. Okay, and then here you can see that you're starting to form bone along the posterior surface of the disc, and that is in contact. The posterior disc is attached to the posterior longitudinal ligament. So that is called OPLL, ossification of the posterior longitudinal ligament. So I'm showing you this just to make the point. The spine just wants to fuse itself to treat its segmental instability. It doesn't care how it does it. It's happy to fuse it through osteophytes, your typical dish. It's happy to fuse it through an interbody fusion. It's happy to fuse it with OPLL, ossification of the posterior longitudinal ligament. It just wants to fuse that segment. And then as soon as these levels get fused, then the adjacent level will fail real fast. You can see in this case, it's just got one more disc space to go before you're fused to the sacrum with your lumbar spine, and it's already marching its way up the thoracic spine. So this patient's headed towards having an entirely fused spine. Not good. Painful, leads to a markedly reduced level of function. Okay, here will be the last case for this part 3 of back pain and Rogers' theory of ischemic and biochemical degeneration, spinal degeneration. This is a more vertically elongated OPLL, ossification of the posterior longitudinal ligament. So here's a cervical spine. This is the anterior arch of C1. Here's C2, the odontoid. Odontoid means tooth. It looks like a tooth. The C2 part that projects up here. And then you can see the ossification of the posterior longitudinal ligament extending all the way up along C2 vertebral body, the odontoid, and then continuing down for a couple of vertebrae. You can also see this poor patient has a developmentally narrow cervical central spinal canal. So their cord is being compressed. So this would be there's C2, C3, C4. C3, 4, OPLL, causing severe central stenosis with cord compression and abnormal signal in the cord. T2 hyperintense abnormal signal in the cervical spinal cord, and that's due to post-compressive myelomalacia, destruction of spinal cord tissue. So this patient's going to have a myelopathy, weakness of the arms and legs, difficulty walking. So this is not good. So patients who are born congenitally with a narrow spinal canal, they're at much higher risk for this to progress to cord compression. And these are the kind of patients who really do need spine surgery, like a posterior decompression, a laminectomy, to get this OPLL to stop compressing the cord. Okay, we're going to stop right there for now. So that's the end of part 3 of this series of lectures on back pain due to Rogers' theory of spinal degeneration, ischemic and biochemical.